Hello, dear friends. Introducing SICOT Pioneer, Programme of Innovative Orthopaedic Networking, E-Learning, Education and Research. What is SICOT Pioneer? A stratosphere built up of cloud and web-based infrastructure that enable communication, storage and on-demand utility of educational resource by and for our membership. The aim of the platform is to encourage cross-pollination and a virtual delivery of goals within the different pillars of the Education Academy and beyond for the global orthopaedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in June 2020 and consist of a variety of educational event formats that encompass all orthopaedic specialties, training, research and innovative practices.
Right, a very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Vikas Kanduja, Consultant Orthopedic Surgeon in Cambridge, UK, and the Chair of the Education Academy of SICOT. And it's a pleasure to extend a very, very warm welcome from SICOT Pioneer to all of you logging in from various corners of the world. In the light of the recent tragic events in Beirut in Lebanon, SICOT Pioneer has collaborated with AIOT to bring you this webinar on disaster management. This webinar will include talks from an orthopedic perspective of disaster, as well as practical advice on the role of WHO and MSF in such circumstances. It's a pleasure to introduce my co-moderator today, who will be leading the proceedings, Professor Onda Ignios from Turkey. He's a professor and chairman at the Istanbul University, Faculty of Medicine, past president of the Turkish Society of Orthopedics and Traumatology, past president of EFOT, past vice president of APOA, and the chair of the advocacy committee in SICOT. And before I hand over to Onda, we at SICOT Pioneer strive to make every session as interactive as possible. For the global audience who are following this live webcast, please post on your comments and questions in the Panopto discussion box as we progress on through this webinar this afternoon in the UK. Onda and our panelists will address these questions as we go along and choose some of them to discuss at the end of the webinar. So without much further ado, Onda, over to you.
Thank you very much, Vikas. Welcome to second AIOT webinar. AIOT is the Alliance of International Organizations of Orthopedics and Traumatology, and member organizations are APOA, Asia Pacific Orthopedic Association, AFORT, Pan-Arab Orthopedic Association, SICOT, and SLAUT, Latin American Society of Orthopedics and Traumatology. And the aim of the alliance is to provide a platform to facilitate communication and to increase the collaboration between the member organizations. After what happened in Beirut in Lebanon 2 weeks ago, we decided to have this webinar on disaster management. The international orthopedics and traumatology organizations are trying to be helpful in these situations. And there is for example, there is a disaster response committee in APOA, a disaster relief committee in SICOT. Pan-Arab, I guess, have a similar committee. We, as the orthopedic surgeons, have always involved in the treatment of the injured people after these disasters, and mass casualty situations are always a challenge. Organizational and financial capacities of our associations are restricted for these kind of situations, but we should find practical ways to contribute to larger scale organizations or more focused organizations like WHO, MSF, International Red Cross, International Red Crescent. I think John Dormans will give you the scope of it. John is the chief of Riley Children's Hospital Orthopedic Surgery and chair of orthopedic surgery and a professor at Indiana University School of Medicine. He is a past president of POSNA, the Pediatric Orthopedic Society of North America. He's a past president of Scoliosis Research Society, and he's the current president of SICOT. John, please.
Thank you, Undar, and thank you, Vikas. So I'm going to spend my 4 minutes just describing the genesis of this webinar. I'd like to thank SICOT Pioneer for organizing these. We have 40-some applications. We've done several. They've been well attended. The Beirut explosion occurred on August 4th, so it's been a little over a month. The statistics that I checked again this morning from the internet are 160 died, over 6,000 injuries. And after this occurred, a number of friends in Lebanon, our Lebanese orthopedic surgery contacts, including Amr Abdullah, the Lebanese Orthopedic Association president, Ali, who's on this call, Mohammed Darwish, the president of the Pan-Arab Orthopedic Organization. And there were lots of conversations. And in the context of these disasters, most of these disasters, there's a predominance of orthopedic injuries. And we see that especially in earthquakes such as Nepal, Haiti, Turkey, etc. But it also is the case with terroristic events, war, and other disaster situations. And a number of us had a conversation, are we doing enough? Are we involved? Are we optimizing our potential to help in these situations? Or would we just be getting in the way? But with the advent of this new AIOT under Undar's leadership, we have this loose affiliation of the 5 largest orthopedic organizations in the world. And I think this is a new opportunity for advocacy. And so this call or this webinar was organized as a result of those discussions. And the realizations were that there are few formal connections. We all have our friendships and know people and we talk, but there are few formal connections. There's a huge advocacy opportunity, especially through this AIOT connection. But we've not really interfaced well with the mega groups such as World Health Organization and those with boots on the ground such as the International Red Cross, MSF, Doctors Without Border. And so quickly we're learning about some new people who have been involved on the ground, Annette, Richard, Terry, Patrick, new friends, and we're trying to create connections and organizations. So the genesis of this call was to build familiarity, establish new friendships, strengthen old friendships, create networking opportunities. I don't think any of our large orthopedic organizations are in a position currently to provide significant financial support or equipment, but we can work together on a communication front. And maybe someday, if we work together and achieve our potential, we can contribute financially and with equipment. And there are some new avenues for this, such as GoFundMe and similar opportunities. So in summary, I'd like to thank everyone for participating. I think the discussion at the end of the formal presentations will be and the hope and the prayer is that we can be better organized and work together and have more of an impact for the next disaster that occurs in the future. Thank you very much.
Thank you, John. Our next speaker will be Ali Hasan Shamseddin. He is the head of division of orthopedic and trauma surgery at the Faculty of Medical Sciences at the Lebanese University in Beirut. He is the past vice president of Pan-Arab Orthopedic Association. He is a past president of the Lebanese Orthopedic Society. and he's also a past chairman of the AIOT Alumni Association Chapter Lebanon. He will be talking about the reality on the ground in Lebanon. Ali, what happened in Beirut was really shocking and very sad. And our thoughts are with the families of the victims and the people of Lebanon. I hope the life in Beirut will return to normal soon. Please, we are listening to you.
Okay, thank you very much, Ander. Dear friends, dear colleagues. I will focus on what happened on the ground in Lebanon just after the explosion, and not on the specific orthopedic injuries. And we may discuss on this during the Q&A.
I'm gonna share the
So,
presentation. That everyone is seeing it.
I am sharing the presentation now. Are you seeing it? Is it okay?
Yes.
Okay.
كيف تكبرها؟
ها؟
كيف تكبرها
ما
البرزنتيشن؟
بتكبرها.
اوكي خلاص نزلت فيها عادي. كيف تنزل فيها؟
مش عم تنزل.
هو كيف تنزل فيها نزل.
مش عم تنزل. Okay. On the 4th of August 2020, a massive explosion at the Beirut port occurred, and it induces in a few seconds at least 200 of deaths, around 6,000 of wounded people, and it left 300,000 homeless and displaced people. And it induced around 15 billion in property damage. The explosion was considered to be one of the most powerful non-nuclear explosions in the history. I have some problems in sharing this. It induced a crater of more than 200 meters in diameter and more than 40 meters in the depth of the port, of the water.
Ali, if you could just press on the presentation mode. Just the play the presentation. Then you can move your slides with ease.
Do you see the slides?
Yes, we do, but just play it in the presentation mode. Yeah, just that, exactly that.
Slideshow.
Yeah, correct. Thank you.
Okay. The explosion location in the heart of the city of Beirut is what it gave the disaster its amplitude. It was detected as a seismic event of magnitude 3.3. It was felt in Turkey, Syria, Palestine, and some parts of Europe, and it was heard in Cyprus, more than 250 kilometers away from the coast of Beirut, and it induces some damages to homes at more than 10 kilometers away from the center of the explosion. However, the explosion location at the sea border, it contributed to lessen the disaster by dissipation of the explosion wave and impact into the open space of the sea and through the water. In addition, the explosion location was just behind the huge and very robust and resisting building of the strategic growing silos of the country. The growing silos acted as an enormous wall and barrier between the center of the explosion and the rest of the city. As you can see on the slide, it was just behind the silos, and the silos, it was between the explosion and the center of the city. So it absorbed a big part of the blast wave, and it also contributed to limit the disaster. The explosion induced a damage to the infrastructures, and it destroyed the major utility facilities, hospitals, and rescue centers. The port of Beirut serves as a vital piece of infrastructure for the importation of scarce goods. It includes the grain silos that serves as a strategic reserve of wheat for the country. So this was completely this was completely destroyed, as you can see. The electricity of Lebanon central location and building, which was located around 500 meters from the port of Beirut, was affected, deeply affected. It was highly damaged by the blast. This induced a total blackout and leave the city into a complete darkness. The remaining private electrical generators that were not affected by the blast were used with a full power to overcome the electricity shutdown. 3 major hospitals were completely destroyed. These are 3 university medical centers, while 2 additional hospitals also were affected by the explosion. Many problems occurred for the functionality of the affected hospitals. Because previously admitted patients to the damaged hospitals had to be urgently evacuated to other hospitals away from the area of the explosion. 5 of the medical staff in affected hospitals were immediately killed by the explosion. 15 patients in intensive care units died after ventilators stopped working following the explosion in the hospitals which were affected by the blast. Injured people could not be admitted because of the damage to the hospitals. Staff of the hospitals were forced to treat the patients in the streets, literally in the streets, as you can see, in the complete darkness at the night. The remaining working hospitals were suddenly overloaded with the lack of essential and basic medications. Medical students, interns, and residents actively participated in treating and rescuing injured people. The medical staff was exhausted as they have to work non-stop over the night. Major fighting dispatch centers located within 100 meters of the port of Beirut was completely destroyed. The Red Cross dispatching center was severely affected as well. The teams of the civil defense, firefighting, and Red Cross from other regions of Lebanon were immediately mobilized to help in the capital. Disaster relief protocols were not efficient enough to deal with such an event because Lebanon also relied mostly on the community engagement, and to overcome the governmental deficiencies, many NGOs and spontaneous civilian response played a crucial role in rescuing the injured. Prominent Lebanese NGOs have played an important role in the disaster relief phase, responding more rapidly than any official governmental institution. NGOs were very efficient in mobilizing their resources, in providing first aid care, securing the funds, food, household items, and hygiene supplies. Some NGOs went as far as providing temporary refuge and shelter for the displaced families. Social media pages flooded with information about where to get help and about reliable NGO to donate to. Tens of new pages were created overnight through individual initiatives to help people coordinate and to provide them with a landmark. Social media helped in the building of a sense of compassion, belonging, as well as a sense of a community engagement. Thousands of Lebanese drove from across the country to offer their helps to their compatriots. Help was given where help was needed through the coordination of the NGOs. All types of volunteering were needed, from raising to floor sweeping to the medical aid assistance to blood donation, child care assistance, elderly support, food distribution, and etc., etc. In conclusion, in my opinion, overcoming such a sudden disaster in a country like Lebanon could not be possible without NGOs' active participation, the solidarity, the compassion of community engagement, the sense of humanity, and the sense of compatriotism. Thank you very much.
Thank you very much, Ali. While you are stop sharing your screen, and our next speaker, Richard, will begin sharing his screen. Can I ask you very quickly, this disaster unfortunately happened in a very difficult time during this COVID-19 pandemic. So can you tell us something about this coincidence also?
Okay, thank you for this very interesting question on the, just to give you an idea, in August 3rd, the day just before the explosion, the registered cases of the COVID-19, according to the Ministry of Health of Lebanon, was 5,417 cases. These are the figures that I have here, and the new positive tests were 117. Now, in August 21, so it was just yesterday, around 3 weeks after the explosion, the positive new cases jumped from 117 to 628. So it increased around 5 to 6 times per day. And the registered cases are now 11,600. So it was multiplied by 2 in just 3 weeks. This may be a very interesting idea to give you an idea what happened. Yeah. Now, the most important and the critical, I think, the critical point is that we don't have enough respirators now because of the damage of the three most important hospitals in the city of Beirut. This is very dangerous now.
Yeah. Okay. Thank you, Ali. Our next speaker is Richard Wheeler. He is a consultant orthopedic surgeon in London. He is best known for his work with the hip joint. However, he has also specialized in the surgery of conflict and disaster, initially as the medical officer to the British SAS and then subsequently on a humanitarian basis. He has operated in more than 30 countries worldwide. So he will tell us his experiences. He's also an editor-in-chief for Oxford University Press. His talk is, "So you want to help out at a disaster?" Yes, please, Richard.
And thank you very much indeed. Ladies and gents, wherever you are, I've been given 8 minutes to summarize 40 years' work. I cannot say everything. So let me dedicate this to those individuals who want to go and help in a disaster. This is for you, because I'm sure out there are many hundreds, if not thousands of people who would like to go and help. Now, I've got to somehow, why am I here? Well, I'm here, I guess, because I've done a fair amount of this over the years. I'm not just a hip man. And what I've done, I suppose, will be reflected in terms of what you might be asked to do. I mean, here we are, a health center on a mountainside in Kashmir, or maybe a health center in Java, maybe setting up a field hospital in Haiti, maybe evacuating casualties from Libya to Tunisia during the NATO bombing campaign, or more recently, perhaps, the great Palestinian March of Return, which was a mass casualty by any standards. So I guess I want to share some of that experience with you. And it does highlight, I think, this diversity of what I've had to do, the role of specialism. I am an orthopedic surgeon. We are largely all orthopedic surgeons. And yes, you will be asked to be a surgeon if you go to these things, but you may also be asked to be an obstetrician. You may also be asked to be a technician. You may also be asked to be a dentist. You may also even have to be a vet. There's all sorts of things you will have to do in addition to what you are skilled at doing. This implies, I think, that you need to develop teamwork. You may be working in a fairly individual type of surrounding at the moment, but teamwork is very, very important. These are big events. They are huge. We've already heard from Ali Hassan what a huge event Beirut has been. I mean, here we are after Haiti, a food riot. Do you know the number of casualties in Haiti were more than the number of casualties at the Battle of Ypres in 1915? So you are a very small cog in a very large wheel, which is very different to how you may be at home. You're used to small teams. Okay, we are all used to this sort of picture, and we may have to get bigger teams or even bigger still. And when you start talking about teams, you're talking about leadership. And when you go for your first disaster, probably you will not be the leader. You may be, but you'll certainly have various kinds of leaders. You'll have good leaders. Mostly there'll be good leaders. You'll have bad leaders that you have to work alongside, irrespective of what you think. And occasionally you, despite your reluctance, will have to be a leader as well. And people often say surgeons aren't leaders, but I would disagree. I mean, just think about it for a moment. During your working day, you're wearing a hat, you're wearing a mask, you're wearing a gown, you're wearing gloves and boots or clogs. You have your back to everybody while you operate. There are 20 people behind you that you have to lead, and all they can see are your eyes. So surgeons, you are indeed great leaders. And in many respects, we would like everything to be perfectly aligned, just like that, in terms of our leadership skills. In a disaster, this is roughly what you get. And you sometimes have to lead that sort of herd of cats, as it were. So there you are, you're on the team, you've got the call, mostly it'll come by mobile telephone. This is a typical mobile telephone call for a disaster. It doesn't say very, very much. All it's doing is standing me by for what is to come. That, ladies and gentlemen, is a now or never moment. If you're on a team and you want to go and help, you say now. All your problems disappear, you keep them to yourselves. If you give the slightest inkling of trouble at that point, probably they'll move on to somebody else. So you then go, okay, I've agreed to go, now what do I do? Now you are likely, you should be properly prepared. I've got a notebook there that I keep everything in, and you're busy working out what you do and how you're going to basically clear all your clinics and everything in the space of 6 hours. You start packing. And the end point of packing for me is 2 bags, okay, are 2 bags. One big one, which carries everything that I would expect a surgeon to have, and a small one, what I call my grab bag. In that is the bag that stays, it contains everything I need to survive. A grab bag has saved me on 2 occasions in my career, and it stays no more than arm's length from me. It goes to bed with me. It goes to the toilet with me. It goes to the shower with me. It even goes in the OT with me. I end up with 2 bags. Now think of friends and family while all this is going on. I mean, you are hyped up, you've got your adrenaline going, and you are thinking about where you are going, but think what they are thinking. They are worried about your security. And just let's have a look at the security. Here we are from humanitarian outcomes. Simply look at those 2 green circles and look that the risk to aid workers has doubled just about in the last 10 years, and kidnap still exists and is increasing. What are these risks? Let's get a little bit more specific. Here we are in Kashmir, where we're going to operate on the line of control. In itself, it is a military problem. That is a military risk. You have an environmental risk. That distance to the mountain there is 1 kilometer. Now, what that shows is the enormity of a single earthquake. But you probably didn't know that after the primary tremor, in the 4 weeks that followed, there were 1,000 aftershocks, many of which were stronger than the original shock. So you are working yourself as an aid worker in risky surroundings. Libya, a lot of this going on. And while you're there in the field doing what you can, these people are back home saying things from the comfort of their offices, and you get blamed for everything they say. So be very aware of security. You're then going to do a long trip. We come to the arrival in country, and you come out of that airplane or helicopter, you are ready to go. You are ready for anything. And then in some respects, you can be quite disappointed. This is the view I had when I arrived in Haiti. It looks, apart from the evacuees trying to get out, it looks pretty tame. But then you get the other side and you realize you have got a major problem. At this point, I would wholeheartedly encourage you to look after number one. Yes, you want to go and treat people, but get yourself organized first of all. Just get yourself over the first 2 or 3 hours sorted so you can actually fulfill the expectations that people have of you. Think of accommodation. Don't expect anything fancy, okay? You probably got a pup tent. You may have a communal tent. I wouldn't feel too fond of hotels at a time in a zone of an earthquake. The food, they will tell you they will feed you. Don't believe them. Take your own food. And I would promise you, the reason I do disaster and conflict relief is because of Nestle's condensed milk. If there's nothing else in life that you should have, take Nestle's condensed milk. It is truly wonderful. Take your own food, and this is the sort of food you'd have to drink. Then you've got to find what's going on. It may seem that you should know, but you won't know. You'll arrive there, you'll hope someone will brief you, they may not. But there are things that they call clusters. And at the end of most days, the NGOs will come together and they will learn what is happening and what might be available for them over the next few days. And then the work. Look, I'm not going to describe the work. We've got far more qualified people to follow me. All I would say is I follow 3 simple rules. I keep it simple, I keep it safe, and I keep it uninfected. I say that with slight hesitation in my voice, because I'm pretty sure my colleagues will pass comment on infection. And then it's time to go home. You stayed there for a week, a day, a month, an hour, however long you've stayed, even a year. And what do you feel? Well, I feel tired. On average, you'll get 3.5 hours sleep a night. I feel inadequate. There are operations I did that I wish I hadn't done. There are operations I didn't do that I wish I had. I feel guilty because I've made friends to get my project going. I feel guilty because I've left colleagues behind me carrying on where I have left off. And so remember, PTSD, it is not the domain of the soldier or the airman or anybody else. It is also in the domain of humanitarian work. And so in summary, you want to help out with a disaster. Be prepared. React instantly. You are asked to react. Keep it safe, keep it simple and uninfected, and be aware of PTSD. And if you go, good luck when you go. Thank you very much indeed.
Thank you very much, Richard. Our next speaker will be Annette Hollian. She is from Melbourne, Sydney. She is the group captain in Royal Australian Air Force. She's a consultant orthopedic and trauma surgeon at Monash Children's Hospital. She's a counselor at Royal Australasian College of Surgeons, and she's the 2nd vice president of Australian Orthopaedic Association. She will be the first female president of AOA. And she has a great experience in these situations. She has been to war zones. She has been to disaster zones, both as a civilian and in uniform. And she has also a role as the deputy director of trauma at the National Critical Care and Trauma Response Center in Darwin. I was the first chairperson of Asia Pacific Orthopaedic Association Disaster Response Committee, and while we are trying to establish this committee, the help of Annette was of great importance. She was very, very helpful, and she will be talking about the challenges to surgical care following a sudden onset disaster, the early response. Annette, please. Can you unmute yourself? Yeah.
Thank you. My talk overlapped slightly with Richard's, but I take it on from where he's left off to talk a little bit about the surgical challenges that we face. And Richard and I, in fact, overlapped in Tacloban in the Philippines in a response to a disaster there. I've had, as Onda said, some experience with disasters and some in war zones as well. I was volunteering in Papua New Guinea in 1998 when a tsunami occurred there. And so that was my first experience. And I think it was the first time I heard the word tsunami. But I then was also one of the first responders for the Boxing Day tsunami. The Australians were the first operating team on the ground after the Indonesians. An earthquake there a few months later. 3 tours of Afghanistan, and then the typhoon in the Philippines. So in my outline tonight, I was going to talk a little bit about preparation of self and arrival in country, but I probably can go through that pretty quickly and then concentrate a little bit more about the type of clinical situations that you'll have as an orthopaedic surgeon. Personally, I think it's really important when you're leaving to go on a deployment to absolutely separate from your work. I've been at airports where surgeons were still ringing colleagues trying to get the patients they had in hospital someone else to look after them. I think it's one of the first things you probably need to do so you can stop worrying about the people at home before you're leaving. You really need to know yourself quite well, what stresses you and how you're going to respond to that. And I think it's important to have a crisis plan, because if you feel yourself really under stress, you need to know how you can get yourself out of that again. When you go, your team needs to be fully self-sustaining, and we have a WHO EMT team in Australia. We call ours OSMAT. It's a type 2 team that can do surgery, and we train with our Pacific Islanders and sometimes near northern neighbours as well, so that we're all on the same page. And if we end up going into one of these areas, it's usually a cyclone or typhoon in the Pacific, then we already know people on the ground there. Before you leave, I think it's also important to get as much medical intelligence you can about the region that you're going to. And I think through our network, it's really opportunistic that we can probably reach out to just about anywhere on the planet, have people on the ground and get some information. It's good to know what the type of climate you're going into and whether there are ongoing threats, whether it's been from a natural disaster or some man-made event. And trying to get some sort of cultural briefing about the environment you're going into is really helpful, because we really provide the best care when we understand the culture of the communities in which our patients live. Trying to maintain our standards of care, I'll come back to that in another slide, but it's the standards that are in the country already, not our what we think their standards should be. And I've put up Christian's contact here. Christian's the man who has the Red Cross on the ground. So if people are looking to make direct contact into Lebanon through Red Cross, he's your man. On arrival in the country, we've faced a few challenges at times. One is the language. If you haven't got someone who speaks the local language, that can be quite a challenge. Having local currency, because you're going to have to somehow hire or buy a vehicle to get you somewhere that you may not even know where you're going. And you're going to have to protect your supplies and take sleep where you can. As Richard mentioned, it tends to be very little. When you get to a facility or somewhere where you can set one up, it's likely that there'll be a very intermittent power supply. You might even be running on generators if you can get fuel for the equipment you've taken. The water supply is likely to have been interrupted. May or may not be an operating room that's functional at the hospital. The ongoing earthquakes can be quite challenging when that's bringing the operating room down around your ears. I always take my own PPE. If you're in a planned deployment, it's likely that will be provided for you. Knowing what instruments you've got, whether it's in your boxes or whether it's you need to go looking in cupboards to see what you can find, is really important. The sterilisation options, because it's not a given. When your hospital's damaged, these things are problematic. And then the referral options for your patients, who's going to look after them when you're leaving. And if you think you're going to get resupplied with anything in the first couple of weeks, think again. Unless you carried it in under your arm, you're not going to have it in that time. Assessing your patient is largely digital technologies. Your 10 digits is what you've got, along with your eyes and your nose. And most of the survivors that, as a team coming in from another country, it will be a few days in, they'll have wounds and fractures because the other patients will have been triaged out of it by then. In earthquakes as well, you'll have a lot of crush injuries that you'll need to think about, and there'll be a large number of people with fevers from a significant number of regions, not the least of which is aspiration pneumonia, if it's in a tsunami where people have had immersion injuries. You need to develop treatment protocols and do only procedures that fail well. Don't do things that are going to create a problem for the local practitioners. If you can find the local practitioners and work with them, it's fantastic, because you've then got a way to hand patients on and have their ongoing care. And as I said before, the gold standard is the local standard. You don't use the ivory tower algorithms that you've left your country with. Very likely there will be no dialysis option, so you cannot afford for patients to go into renal failure. And where we usually have our emergency department people managing the tetanus prophylaxis, you'll actually have people with tetanus, and you'll need to learn how, not only how to prevent it, but how to manage it. You're going to have a limited supply of antibiotics, and you'll have to work out a way to ration those antibiotics and work out a plan for how you manage your open fractures, say, that's consistent. And then you'll have to work out which patients are your priorities. And I have to say the ones with the bad smell, as I say in the ICRC, is the ones to go for. Just because they've got a fever doesn't mean they're the surgical emergency. You have to watch out for the malarias and the pneumonias. After that, I tend to go for the open fractures and open joints, followed by the open draining wounds, and then the closed fractures. The wounds are, it seems so basic, but you really should not have it be anybody suturing wounds, and you'll spend a lot of time taking sutures out. In fact, this young lady in the image had a slight bulge behind her leg, and when I lifted up underneath, this filthy grey pus that I've never smelt anything quite so bad came pouring out, and she needed her leg laid open from her knee up to her hip. You excise the, so you can wash. It should be, drinking water's fine. You don't need sterile saline if you have got a limited supply. And then you're only excising the dead and devitalised tissues. You have to lay the wounds open because there is necrotizing fasciitis and there is infection at the level of the subcutaneous tissues. In thinking about the handing over, you've got to think about communicating what you've done to the patient, to the family, and to the health staff coming after you. So drawing on the bandages I found really helpful, taking photographs of the operating notes. In open fractures, it's a similar approach. I always give the patients a good scrub down beforehand, as well as a wash after the prep and drape. You need to close the wounds, you need to close the joints and use some sort of external fixation or splinting or traction while you're waiting for a time when it's safer to do internal fixation. In closed fractures, said it's rarely the priority one. They need analgesia and they need to be splintered until you can reduce them and stabilise them. But tend to think about plaster or traction. And again, communicating by drawing on the plaster I found incredibly helpful. I'd resist using fiberglass because often people don't have a power saw to get it off again. Compartment syndrome will be a problem if you're going into an earthquake area. And in particular, the thought that you might be wanting to do fasciotomies, you have to hold back unless it's less than 8 hours ischemia. Otherwise, you get likely to precipitate a problem and convert a closed fracture to an open. Amputations may be the best option if someone's got gas gangrene with their consent, which is not always a given. But if you're needing to do one, make it as distal as possible with the skin longer than the bone. It doesn't have to be the definitive length to start with, but it should never be in a guillotine procedure. Always leave the stump open because it goes on to great badness. And if you're expecting someone needs an above knee amputation and you can do it through the knee at the first stage, consider that because there's far less blood loss with a through knee amputation. You will face ethical dilemmas. And you need to consider, it might be around the allocation of resources. It might be about whether you're doing amputations, and it might be a parent who doesn't want you to do that, or withdrawal of care from your patients. So I suggest you have a senior clinical team that can gather along with some respected member of the community who can help you make those decisions. So in summary, it's about preparing your team, doing surgery that fails well, consulting with the local community. If patients are needing internal fixation, it's trying to find those local people that you'll be able to get those off to do that internal fixation because they need long-term care. Thank you very much.
Thank you very much, Annette. You have a military background and you're not only experienced on natural disasters, but also on war injuries and terrorist attacks. These are also sometimes cause of mass casualties. What are the similarities and differences between these, I mean, the natural disasters and the other explosions, terrorist attacks?
Natural disasters, I tend to have arrived a few days later, so often it's a single limb or two limb injury, whereas in a war zone, it may well have to be a multiply injured patient that we're responding. So we could well be having to look after head, chest, abdominal injuries at the same time as limb injuries. The disaster ones are often much dirtier wounds. There's often such a delay between injury and treatment than if you're in an active war zone and getting people quickly. And I guess the other part is the emotional response, because I found it much easier on me emotionally if I'm looking after people from a natural disaster than people who have had injuries inflicted upon them by others.
Okay, thank you very much. Our next speaker is Thierry Begui. I have the pleasure of knowing Thierry for so many years now. We worked together in EFORT board and in EFORT Science Committee. He was the chairperson of that committee. He's a professor of orthopedics and trauma at Antoine Becler Hospital, University Paris Sud, and he's one of the founders of ESTROT, European Society of Tissue Regeneration in Orthopedics and Traumatology. And he will be talking about team management. Yes, please, Thierry.
Thank you, Ander. Thank you, Vikas. I will focus my talk about the team management because, as you saw from the previous speakers, how to manage when you are devoted to treat in massive disasters. The experience we have was built and was confirmed based on the Bataclan attack that we had for a few years. Try to work and to go to my presentation. Yes. Where in this Bataclan in November, you know that in fact it was in Paris, and as Ali Shamseddin exposed, the problem is the number of hospitals available. In case of this type of injury, of massive attack, 16 hospitals were involved, and at the first time, we had a lot of different operating rooms working at that time. This is exactly where the different attacks has been there, and you can see the amount of hospitals in Paris and suburbs who were involved in this massive disaster. In each of them, one or different teams were available just to do the surgery. You see the amount of absolute emergency was not so high, only 76, but the relative one were quite high, and I will focus on my subject in this one. Well, we have a specific plan in France about that, but it's based mainly, at that time, it was based on the military attacks, and nowadays we are just changing. At the beginning, in the early phase, when you have your local team, the need for orthopedic traumatologists is quite limited because it's mainly thoracoabdominal emergency, of course, in case of massive limb bleeding. The report on the right is coming from one of the military hospitals we have in Paris, and you see that based on the NATO system, the first huge emergency went directly in the OR during the 5 rooms available at that time. But for the different teams in orthopedics, I will say that you have to protect your teams for the next days. In orthopedics, you will not do all the job in the first hours, not in the first day. You will need to do that in the next days. So the team organization needs to be at time during the first day quite important, but of course you need to have also some team for the second day, third day, and as the previous speaker spoke about, even down to the 15 days after that. So that you need to save the team, you have to divide them, to send back home some of the surgeons that want to help during the first time, just after the massive disaster or injury. And after, it's one referee, one senior guy, must centralize all the information and do the surgical indication. Because the indication of surgery will be different depending on the importance of the patient that will come. We heard about the earthquake in Kashmir that was a second afterwards after that. Nowadays, we are mainly using the WHO triage for massive disaster, which is quite different from the one from the NATO. And of course, we are focused on the yellow criteria and the red one. The green one must be referred to only splint and orthopedic treatment and nothing else, of course. So you have to go to the emergency. And the main difference that we had as a conclusion is that when you are in a civilian massive disaster, it's quite different from the war-related injury. There is, in case of a different type of injury, there is no possibility of evacuation in case of a war-related one, because, but in Paris, we had a lot of hospitals available, not only in the city, but also around the city. And the first speaker spoke about the problem with some hospital close to the bombing situation, to the explosion situation, where the hospital was unavailable. And I think it's part of the difficulty to know exactly how much hospitals and how much possibilities are available. Of course, I think that the exofixation and damage control orthopedics must be done in all those cases. Well, nowadays, in civilian context, I think that the management at the beginning will be DCO, damage control orthopedics, and after the different team will be able to go either to a definitive X-fix or to change to a different thing. There is mainly a situation where you can have, and the context of mass casualty will go to triage. It's the right part of the slide, where the triage and categorization will be the main situation you have to face. In some case, even if you do the surgery at that time, with a vascular surgeon, like in this case, we have done a debridement, a vascular shunt to this guy after this X-fix and try to salvage the leg. But in fact, we have additional section, and we saw that all the artery were completely involved. So we decided to go to amputation, but only after 4 days. You can do even simple damage control, and you have to wait for at least 10 or 15 days. With another team will do the job. But if, in some case, you can go with this additional surgery with different type of technique. I will focus my main program about the logistic aspect. You have to protect your team. You have to organize and schedule time, schedule day for not the first day, but also the day after and even after the first week. You need to evaluate all the case, all the patient, and I think that you must do that as a pilot, as a senior surgeon. You will be able to make the indication, and the indication and the treatment will be managed and depends, of course, on the number of cases. In case of iterative massive injury, patient can come, depend on the number of orthopedic teams. And as the previous speaker spoke about, the steroid products is one of the major problems that you have to face. My additional conclusion will be that you can be confident on any of your team, even if they have no experience at the beginning about massive injury. Where in our experience, we did not have so much revision after the first day surgery, and the good indication at the first time is the best treatment. But the second problem is probably the emotional aspect. We spoke with the previous speakers about the experience they have managing this amount of disaster. But if you are working on a local aspect, you have usually young patients. Usually the surgeons are the same age as the patient. And it was one of the major issues we saw during our massive attack in Paris. And to try to avoid any exhausted teams. And of course, you need to have additional psychological support after the crisis. Thank you for your attention. Thank you.
Thank you. Thank you very much, Thierry. Our last speaker is a senior orthopedic surgeon, Dr. Patrick Herard. He's a surgical advisor for International Medical Humanitarian Organization, MSF, Medicine Sans Frontières, Doctors Without Borders. Based in the operational center, Paris, his responsibilities include establishing protocols and responses to improve trauma care, particularly in emergencies such as conflict and natural disasters, mostly in unstable environments. He is also a consultant for WHO and member of French Academy of Surgery. He has extensive experience in management and recruitment for international private medical companies and as a senior orthopedic surgeon in France and in some other countries. Yes, please, Patrick.
Thank you very much for the introduction. Okay. Okay, is that okay? So
yes.
Okay, so I will explain mostly. Well, it's extremely difficult to say in 6 to 8 minutes all the challenges we face with this kind of problem. Anyhow, there are structural and logistics, there are medical, and they are for the recruitment of the surgeons. Security, finance, very often a limited access to the medical care, sometimes high resistances from authorities, and of course, difficulties for rehabilitation. In terms of medical, there are ethics, very often with late presentation of the patient, and quite often you don't have X-ray or lab test. And for the recruitment, the specialization of the surgeon nowadays is a real problem, and there is not a lot of training to switch from civilian practice to field surgery. This is just a short view of what we do per year within MSF, and we roughly between 30 to 40,000 procedures per year. And as you can see, burns are a huge part of it. Of course, when you go to the field for a disaster, this is what you will see. But also, you will see this late presentation, and you will see a lot of domestic burns because the houses have been destroyed, and you will find a lot of burns. And again, these burns represent 20 to 30% of the activity in this kind of setup. Epilepsy, boiling water, whatever. So then you have a confrontation with the ethic of the patient. First of all, as much as possible, you should have an informed consent when the patient, especially for amputation, but you may face cultural or religious concerns. Just don't forget that in some countries, you just cannot amputate. And the violation of the local bans, for example, may compromise totally the whole team in the mission. Then you have limits, of course. We should be limited to the treatments which were already available before. What about assisted ventilation? What about dialysis? What about head and spine trauma? We just cannot do them. This is just a short map to show you, according to the area where this kind of event will happen, according to the income per person, you have the life expectancy. And you can imagine that, of course, when such event is happening in Niger or in Pakistan or in Japan, of course, your answer will not be the same. The logistic part is fundamental. You cannot go to any earthquake or thing like that without a proper logistic support, electrical power, transport, OT setup, hygiene and sterilization. Waste management is quite often missed. And we are working for MSF with kits. They are already prepped. We are not the only one, but we have really full kits ready to go at any time, any day. The training. The problem of young surgeon now, more and more, the general surgeon doesn't exist. The visceral surgeon now is an endoscopic surgery one. The orthopedist, more and more, is a knee surgeon, a spine surgeon, and he doesn't know anything about war or disaster wounded. Obstetrician, they rarely seen a ruptured uterus. They don't know technique like symphysiotomy or craniotomy for that fetus. And burns in our country are treated by plastic surgeon. So you cannot go on a mission on this kind of disaster without a previous training in a similar environment. And you will never go for MSF as the first mission to a disaster. Then disasters are not the same. If you look at these figures and the difference between earthquake and tsunami, for example, the tsunami kills, the earthquake wound. In green, you have all the wounded for the various earthquakes, and in red, the dead. And on the right part of the figure, you have the dead for a tsunami. So to send a full team for a tsunami is a mistake. You will have a very small number of wounded, just at the opposite of the earthquake. You had this predictive graph done by Karolinska Institute in 2008. And this was the theoretical curve of what will be the workload when this kind of event happen. And if you look at what we've done in Haiti, with over three months, we did 5,500 procedures, and you can see that the curve, we are not theoretical, only theoretical, they are very realistic. So I want to focus mostly on Haiti. People already spoke about it, but there was a first disaster. And this was, of course, the picture everybody knows. But there was a second disaster. You had more than 300 surgical teams going to Haiti. According to WHO, only 35 were qualified or considered as competent. Many came without tetanus prophylaxis, no waste management, no logistic. More than 1,000 amputations were performed, and a lot of them were not justified. With a poor knowledge of what is the correct debridement for these war wounded or earthquake or whatever, with a wrong idea of a proper timing for fasciotomy in this kind of setting, it has already been explained. So this is exactly what's going on. You see, on day one, you operate in the street like it was shown for Lebanon. And this is what we did after, this is a picture 3 weeks after the earthquake. And you can see from day 1 to day 12 where we were able to operate in inflatable tents. Same thing for sterilization, starting from the most basic one to proper TBM. We had 3 OT rooms, 1 recovery, 2 dressing room, and same thing in Pakistan and Gaza, Sri Lanka. On fractures themselves, on the earthquake, you can consider that most of your fracture on the upper part of the body are closed fracture. If you look at the data of Haiti on 200 long bones, 67% of humerus fracture were closed. At the opposite, leg fracture, 77% were open fractures. Amputation, debridement, fasciotomy, canal fixation, it has already been a bit explained by previous orators. Fish mouth amputation, left open as it was said, no guillotine amputation at all. Extensive debridement and secondary closure and basic flaps, it has already been said again. Proper timing in compartments syndrome need experience. There is a good survey by done in, I think it was in Turkey, when you open, when you do a fasciotomy in this kind of setting, it leads to 70 to 80% of sepsis. And basic treatment of fracture is quite often done by external fixator, but just remember that a quarter of them will lead to non-union or bad union or malunion. So it was decided after all this problem of IT to set up a meeting in Cuba, and the conclusion were that it was a real need to do a classification system to have people going with the type, the capacity, and servicing with minimum standards in terms of logistics and in terms of competencies. You have 2 books that you can download free from their website. One from WHO with the classification and the minimum standard you need to go there. And the other one with RCRC and AO, where you have a description of the management of limb injury. It was already said by Annette. And don't forget that after this kind of event, you just go, most of the team will go for 2-3 weeks or for 4 weeks, but it's not the end of the story. And you really need to think of the reconstruction phase. And this is exactly what we do with a kind of hub, center for reconstruction in Amman. This guy, the leg of this guy cannot stay like this. This is really a social life saving. Same for this kind of injury after a war injured patient. So humanitarian surgeons should be really psychologically and technically ready, it was said. Psychologically, it can be a very destabilizing experience, losing the landmark. It was the security, stress, cultural, religious. And technically, don't forget that practice is often totally different from civilian one. So overall, you need a strong personal motivation. Conclusion, you cannot imagine to go and work there without the logistical capacity. This is the only way to provide safe, timely, effective, efficient, and equitable and ethical treatment. Each situation will be different. Context, economic, size of the disaster, and so on. Aggressive debridement, delayed primary closure, and external fixation are gold standard for this kind of setting. Don't forget, data collection is very often missed, and it's very difficult after to improve and to see exactly what was going right, what was going wrong. And second phase of reconstruction should never be missed. At the end, training as the key for this kind of thing. So do the greatest good for the greatest number. Thank you.
Thank you very much, Patrick. Now we have the presidents of the member societies of AIOT with us, with the exception of SLAT President Horacio. He has to attend a meeting in his hospital in Buenos Aires about the master plan of his hospital about this COVID pandemic. And one of the points that you made during your talk, Patrick, it was very important. Nowadays, we are training is mostly focused on some subspecialty concerns, I guess. So sometimes we are missing the general view. And I don't know if any of our presidents want to tell about this or in any other issue about this. Yes, please. Yes, Professor Doral, Mahmoud Nedim Doral, the president of APOA.
Yeah.
Yes.
Okay. Thank you, Ander. Thank you, because it was a wonderful meeting via Zoom. We learned a lot from Corona because we tried to make our meeting on Zoom. Dr. Gerard said training. Dr. Villard said be prepared. Then Dr. Thierry said to protect the team. And I want to ask to Ali Shamseddin that because you are on the platform, you were on the platform, what was your strategy? Because the protection of the medical staff was the number one. The second part, we are talking about the terroristic attack. This is not only one disaster. We have to think also the complex disaster because terroristic attack with pandemic. We have to give our support in two ways because in 2015 in Bataclan, in Paris, it was only one terroristic attack. But now there are two terrorist disasters. And this is it was my second question. But the first question, personal protection of the team on the platform. My question to Ali Shamseddin.
Thank you.
Thank you.
Okay, thank you very much, Nadim, for this question. You know, when things happen suddenly, and as I showed in some of the pictures, patients were really treated in the streets. And with this huge number of patients who arrived in the same time, I mean, when you have more than 6,000 injured people coming to a few hospitals with very limited resources, you know, protection was not really the first thing to think about. And as I mentioned, the cases of corona patients dramatically increased since the explosion occurred in Beirut. It was multiplied by 2 to 3 times in only 2 weeks. And you know, protection was not really the first thing to deal with.
Thank you.
Yeah.
Thank you.
Andre, I have a question, if I
Yes.
may. Yeah. So it's rare to have all the heads of large organizations, orthopedic organizations in the world together. And I want to just get a sense of where do they see, each one of the individuals out here, the role of these orthopedic organizations in disasters like this. Because as Patrick mentioned beautifully in his talk, there were more than n number of organizations in the high-IT situation, which were probably doing the work or not doing the work. Where do we see our roles? these organizations in disasters like this. So Annette, probably starting with you, you'll be taking over the Australian organization soon. What are your thoughts on this? You may be a bit biased, obviously.
You surprised me because I'm not one of the leaders at the moment. I think the networking and the ability for us to be able to reach around anywhere into the world to get information and share that with each other is really critical. I think the relationships with WHO and the training through for EMTs, along with MSF and Red Cross, if we have those connections established, we won't have to try and work out who's who when something happens, no matter how we can help. But I think establishing the network, not only amongst the orthopaedic surgeons, which is really underway, but with the organisations that are on the ground and ready to respond.
Thanks, Annette. John, what are your views?
Yeah, I think Annette said it very well. I think it's the networking and communication, and we don't want to reproduce what's already being well done out there, but I believe there is a huge opportunity to work with all the major, the mega groups, including International Red Cross and World Health Organization. Know who the orthopedic surgeons are on those leadership boards, try and position our young leaders to get involved and get interested. But if, Patrick said the World Health estimated that 10% of those arriving are qualified and the others may be getting in the way. So how can we get that message out and empower the 5 major orthopedic groups to have better communication and networking with the people who are undergoing a disaster?
Thanks, John.
I think the other big observation is it's the neighbors who helped the most. When the Nepal earthquakes occurred, it was the Indians who rushed in and helped. In Haiti, it was the United States and Cuba, the local neighbors. How can we facilitate that through our different networks and still interface with the mega groups?
Okay. Klaus, your views?
First, I do apologize if my internet connection is not very stable. I'm in the Ligurian mountains here. I think besides the networking aspect, which has been discussed, a critical aspect is also education. And I think what we are doing today and what our organizations could even more do during our courses and congresses is to focus on education, how to deal with these disasters. And I was very impressed not only by the first presentations of Richard and Annette and Thierry. I was also very impressed by the presentation given by Patrick, who clearly showed that not everyone who feels that he is ready to go into such a situation should go. And I think we as organizations should probably concentrate a little bit, or could concentrate a little bit, on education and on formal providing mechanisms. What is the necessary equipment, training status, and education of someone who is going into such an activity? I was very impressed by that presentation, and I think we as organizations could do a little bit more on that side. AIOT, for example, has in the Congress is always 1 or 2 symposia on disaster management. They are very well attended, and I think it could be more. We could do more on that, because obviously there is a need to educate people, although we can obviously not train them, but we could deliver basic principles. And again, thank you very much for the presentations I was listening today.
Thanks, Klaus. Mohammed, your views? So we've got networking, we've got formal education. You want to add to that?
Sure, I think we need to train people. And like SICOT, you have now a diploma. We can have a diploma for disaster, for example, which people prepare and study for that. And also, if we could recommend that disaster management should be added to the government-wise, to training in hospitals, and like the trauma doctors who come out, they've never been trained for disaster. And disasters are different. It's earthquake, biological, so many things. So I think maybe they should add that to their trauma surgeons to make sure that they will have in the future people who are prepared in these cases. Thank you.
Richard, you've led a lot of organizations. What's your view? What's required?
Well, it's the sort of the elephant in the room, which I think people have alluded to, but they haven't actually described. And that is, and Patrick said it very, very well, in that they're not going to take people without previous experience. And out there, we've got many hundreds of people listening, all of whom would like to, or many of whom would like to undertake this sort of work. And we're in the situation where you cannot go unless you have the experience, but you can only get the experience by going. And I don't quite believe that we as an organization have managed to solve that issue. There are courses to go on, but when the chips are down and people are called, they're called in a hurry. The organizations tend to call those people they trust who've done it before, who are on a book or whatever it may be. And there are plenty of people who would like to get to that point and have yet so far not been able to. And I think that's something we haven't really solved, or if we have, I've missed it.
Thanks, Richard.
I think these are really catastrophic situations, and as Thierry mentioned, we should trust our team, even if they are not experienced, but we really need the experienced people. We really need them. And wherever these things happen, I think we should find better ways to send these people to appear there, to organize the things with their previous experiences, because sometimes it takes a long time to get organized.
Thanks. Patrick and Thierry, your view from the MSF and WHO, how can organizations like ours be helping?
I mean, you can help a lot. It's false to say that, I mean, what I just mostly wanted to say is that you cannot send as the first team going on an earthquake people who are not trained. But people who are not trained may come after 2 or 3 weeks, and they will learn there. Then there is another way. You go for a mission with RCRC, MSF, whatever, and then you will have a first mission, and you will know what the protocols are, how to deal with open fractures, why you should not close the wounds, and so on. If you have done a first mission, then and we have a specific training after. We within MSF once a year we train 25 to 30 surgeons to deal with the problem, but they've already done a first mission. So you can help it up because a lot of surgeons, I'm sure that a lot of orthopedics are interested to come and to help, but they should come and ask for a first mission, even a simple one. But just to understand what the logistical problem are, what the basic of the wound treatment are.
My answer is we can include inside the initial education program of all the orthopedics. Part of the educational program can include this type of management, how to deal with that type of disaster. We spoke that we have a lot of different disasters available, not only a terrorist attack, but also earthquake, also bombing and so on. So we can include that because I agree with Patrick. Nowadays, all the surgeons are more and more qualified in a very specific area, on the knee, on the joint, on the hip, on the spine, and even the abdominal surgeon, they don't know. The only one in our country who can do all the type of these surgeries are the military guys, because they are trained to go on a field for the war-related injuries, and that's all. But the civilian surgeons, they must be trained in that. So, for example, in France, we have added one specific program about management of disaster for surgeons, and if they want to be part of the MSF technical guys, yes, of course, they need to have this training program.
So there is a potential of and almost a diploma run by these 5 organizations in collaboration with MSF and WHO to train surgeons who are likely to volunteer for disasters like this. Would that be a fair statement?
Klaus, you were the chair of the AIOT Education Committee, and you were very active while it was the European Education Platform was formed and the curriculum was prepared. What is your take on this? I mean, this international collaboration and Vikas' question.
I would clearly, I must confess that I'm a super specialized orthopedic surgeon, and my main knowledge is not the field of disaster management, you understand. So it's a kind of a theoretical contribution what I can give to that round. But I was learning a lot today, and I think what Vikas is proposing makes a lot of sense.
Yes.
It supports what Patrick has clearly lined out, and I think this would be a trial worthwhile to go. The only problem is I do not know if our societies have a critical mass to really create something which is seen as a valid contribution to that problem. As Thierry said, military guys and others have a lot of activity in those fields, and I'm not sure if our organizations can really contribute something. Patrick maybe can comment if he looks at our organizations, and I mean, he is the one who is really obviously in the middle of these activities. It would be interesting to hear from his point of view if our activities in a kind of shared license or shared certificate would be of help.
Well, I'm pleased to answer that. It's a good question. I've been at SICOT congresses for the last 8 years, something like that. And each time the catastrophe or the treatment of catastrophe was either at 8 o'clock in the morning, day 3, or late in the afternoon, or at 5 p.m. So I'm not sure that you will attract a lot of orthopedic surgeons to this kind of presentation with such timing. I think what you could do first, it's just my opinion, is to have a real in the big amphitheater, just a symposium on disaster, how to deal with, how to attract the surgeon to go there, but not at 8 a.m. in a small room.
Patrick, the joy of meetings like this is that there are more than 1,000 people around the world who've signed up. So we wouldn't need to have a session at 8 a.m. in the room at all. So you're okay there. You know, there are 1,000 people listening to this and will continue to listen over the next week or so. So I think that problem is solved.
I will see how many will apply for MSF in the next weeks.
Because I think Ali Hassan wants to make a comment.
Yes, please.
Yes, I believe for have seeing a lot of wounded in many wars in Lebanon since 1975, I think that the orthopedic, injuries, the injuries to the limb are the less really urgent things to deal with when we receive, injured people. I believe that abdominal injuries, lung injuries, and head injuries are more important to deal with in the emergency setting. This is what I want to say only. I don't know what do you feel, what do you think?
Of course,
Patrick and Thierry.
Yeah. Patrick?
Sorry, what the question? Sorry.
The prior.
The question was that the main injury and the main emergency are neurosurgical aspect, thoracic injuries and abdominal surgery, and not so much orthopedics one. So as we are more and more trained in only orthopedics and not in general surgery, how to deal with this type of management. And of course, if we go to SICOT, we will just see only orthopedic surgeons, and the main, the major emergency are not in our field. So how to train those guys?
No, I don't think it's realistic. Head injuries, first of all, we have a small number. Then I've seen one head injury surviving after surgery on the field and for surgery under tent. They all die. I'm sorry to say that, but it's a reality. We don't save them. We have a very small number and we don't save them.
Yes, Patrick, but the question is not this one. The question was, the majority of the real emergency are thoracic injuries and abdominal surgery. And it was exactly what we saw in Bataclan. So the orthopedic surgeon can help, but they will not be the first surgeons. So how to manage, as for example, if you go to SICOT, if you go to AIOT, if you go to all the international organizations we are sharing, you are not anymore a general surgeon. You are only orthopedic. How to train the guys?
Sure. But the Bataclan is totally different from an earthquake. When you arrive on an earthquake, you arrive on day 2, 3, or 4, and they are dead. Your thoracic injuries, abdominal injuries, they are dead.
Yeah, but the question from Ali is, what he saw, it was that at the emergency in Beirut was mainly the problem of the thoracic and abdominal problems after the explosion.
Yep.
What I mean that orthopedic surgeons are not in the first line in such disasters. This is my point only.
Exactly.
Yeah.
Thank you.
But I think when we come back to the proposal of Vikas, I think our aim should not be to train orthopedic surgeons to act now as general surgeons. I think it was more or less a proposal to concentrate on our own competencies and to say we are trained orthopedic surgeons with a special certificate which enables us to show that we have certain capacities in our special field and not going for treatment of head or thoracic or abdominal injuries, but at least showing that we have a core competency in musculoskeletal surgery regarding those disasters.
Yeah, so Klaus, that's absolutely correct. What I was trying to get to is, it's probably a 3-phase project. We obviously will need to write to all our members and find out who is actually interested in being trained and going on missions like this. And because we've got the strength of numbers now, 5 organizations, even if we get 100 interested members, I think that's a lot. And then the second thing would be to have a program in collaboration with MSF and WHO exactly as to what is required on the field, and then be able to use all these 5 organizations and probably mediums like this on the internet to be able to train people and hands-on as well. But if we start somewhere, if you've got the concept clear and agreement from all the societies, then at least that'll make a good start. So that's the thought process.
Yes. And
you need to have a very close relation with organizations like MSF or the WHO, because even if you have the numbers, you will not be able to enter the field without official body. And I think we need a lot of cooperation between the association and the MSF to reach that sort of help.
Yes.
Yeah, agreed. Richard, you've got a point.
Yeah, I had a brief point really, was that, some courses already exist. Typically we have in UK, the STAE, the Surgical Training for the Austere Environment type of course. So some courses do exist, but and one can create others and one can get them perhaps more recognized by the major organizations. But part of the issue is that these events are actually quite uncommon. So you train people up, they qualify, and then they twiddle their thumbs for 2 years or 3 years or 4 years. And so it's the ongoing, how do you keep them interested, which again, hasn't really been solved.
Yes. And I think, as Patrick mentioned, we should bring these issues to prime time in our congresses also. And we are all trauma surgeons. Of course, these situations have some special impacts on our practice. For example, an amputation after a crash injury, after an extremity which was left under the debris for so many hours. It's different from a diabetic amputation or others. So we need to know more about this. I think because we are getting to the end of this webinar, and I would like to thank SICOT and you, because as the chair of the Education Academy, and for leading the SICOT Pioneer Program to give the AIOT the opportunity to bring this issue. I think maybe it's better if you can announce the next webinar and close this one. Thank you very much.
Thanks a ton, Onder. John, any final words from you? And then we'll draw this to a close.
I'm not sure I can really add much. I think it's been a great discussion. Hopefully we're one step closer to having a united response to the next disaster. But I think we're left with guiding principles, and the different leaders of the different groups can come together and try and create next steps. But thanks to everyone, especially Undar and Vikas. I think this was a great discussion.
Thanks, John. So on the behalf of SICOT Pioneer and AIOT, I'd like to thank all the speakers for excellent talks. I know I've sort of shortened the times, and thank you very much for keeping to time and giving us a comprehensive overview. We'll keep you posted. We plan to do another one over the next 3 months or so, and we'll draw on your experience again, if that's okay. And with that, I'd just like to announce our next webinar on pathological fractures, which is on Tuesday, 25th August, led by Professor Pietro Ruggeri from Italy. And Onder, if you could just move to the next slide, which is the feedback slide, the previous one.
Unfortunately, there isn't any here.
The previous one.
Yeah, is this the one?
Yeah, that's the one. So that all of you who've been attending this webinar live, just taken this QR code. We really need your feedback, how to improve these webinars, what else to add. Thank you very much for your questions. We'll get them answered by the speakers to you if we haven't been able to cover them. And thanks a ton for attending. Once again, thanks a ton to the faculty and Onder. Thank you very much indeed.
Thank you.
Thanks a ton.